And so, and so I'm absolutely delighted to be joined by such a stellar panel today. We're thrilled to be launching our new report that my colleagues will be presenting shortly. And a huge thank you as well to Amgen, who have made this project and this webinar today possible. My name is Lily Parsi. I'm Head of Policy and Influencing at the ILC, and I'll be chairing our webinar today, though you'll hopefully be hearing a lot more from our panel than from me. ILC have been working over the last 25 plus years on this topic of how we make sure that long lives are not just longer for all of us, but that we're spending more of that time in good health, that we're more productive, that we are happier for longer. And clearly UHC, or universal health coverage, is a key element to that, to make sure that health outcomes are improved, but also that we're able to work for longer and so on. And it's really promising to see that over the last 2 decades, particularly in low and middle income countries, we've seen huge strides made in terms of UHC. However, these countries are now facing a major challenge. So while currently low and middle income countries are still relatively young, there's a big kind of change coming. So of the billion people worldwide that are aged 60 and over, currently about 70% of those people live in LMICs. By 2050, this number is set to more than double to 2.1 billion, with 80% residing in LMICs. So clearly, while the fact that we're living longer is a great thing, we need to make sure that health systems are adapting to this. And basically, we're arguing that to reach UHC targets, countries across the world, and particularly LMICs, need to be quick on the ball to adapt to this demographic change. So today we'll be presenting some of our new findings, some of that relatively big picture, and some that we did alongside HelpAge International talking to older adults in a number of low and middle income countries. We'll then bring in our expert panel of speakers that will be discussing our findings. So we have Dr. Pamela Cipriano joining us, who's the co-chair of UHC 2030. We have Dr. Socorro Escalante, who's the WHO rep for Mongolia, as well as Professor Srinath Reddy, the former head of public health in India. As we move through the webinar, please also add your questions to the Q&A function. So you'll see that at the bottom of your screen, and I'll be bringing those questions into the discussion. And I think I'm going to get us off to a flying start. So I'd love to hand over to Sean Lybrand, who's joining us. He's Executive Director for Access to Healthcare at Amgen. Thank you so much for supporting this project. And over to you, Sean.
Thank you very much, Lily, and thanks to ILC UK, HelpAge International, and the many interviewees who have contributed to this report. My group within Amgen focuses on low and middle income countries in which Amgen doesn't have a presence, and I was very pleased to support the report for 2 reasons. One, as a beneficiary of universal health coverage growing up, I've seen the impact of that and how it's implemented in a high income country context. On the other, I support and focus on health system strengthening in low and middle income countries where UHC is developing, nascent, in some places non-existent, and know that in order for us to get healthier, we have to be able to age healthier at the same rate, preferably age before we get sick. So thank you very much today also to Dr. Cipriano, Professor Reddy, Dr. Escalante, and Caitlin. I might start with a few opening comments. And we know the world's off track to reach the Sustainable Development Goal metrics that were established for universal health coverage. But we've also got to acknowledge the magnitude of tasks that face national governments, especially those who are in the process of developing it. We certainly can't ignore a number of major factors that have impacted the progress towards universal health coverage: the global financial crisis initially, the global pandemic, which frankly we failed globally to recognise and prepare for the impact of, and now we're dealing with the fallout of in countries, particularly where their debt loads have changed to pick up the debt from health. So it really shouldn't suggest that countries haven't progressed towards their UHC goals. We're definitely much better off than we were 10 years ago. UHC is most definitely a driver of reductions in health inequality, and its growth is an important part of the progress in nations for both their health and their wealth. So we should acknowledge and celebrate progress. In health, none of us should be alone. and progress for one country is progress for all. A cautionary note, though, while health should be a universal right, it does remain a privilege to be able to access quality and affordable healthcare in many countries, and we can collectively do better. The importance of the report today is to acknowledge the impact of aging populations and health systems. As I said before, populations are definitely growing older, and we can do better with that. That's often a result of better healthcare, and populations can be more productive when that occurs. However, growing older has consequences on health, and those consequences are driven in many ways by the rising tide of non-communicable diseases. Cardiovascular disease and cancer among two of those largest areas, and they're a consequence of aging. So growing older while remaining as healthy as possible should be an important policy principle. And to do that, we need to listen to the voices of those people who are or are going to be impacted by the health system as they age. So our report today and our speakers will address a number of pertinent factors that come into the process of thought and implementation of universal health coverage. The factors that are relevant to considerations at the country level and actions that are being taken internationally to help keep us on track as much as possible for the best possible attainment of health for our communities, especially those of older age, whom we should acknowledge and celebrate in this UN decade of healthy aging. Thank you, Lily.
Thank you, Sean. And I think you're right. Clearly, there is, this potential of a really big additional pressure on health systems that, alongside everything that has come, we really need to be prepared for. I'd love to pass over straight away to Aaron Himawan, who's our Senior Health Policy and Research Manager at ILC, to present the findings from the report.
Right. Thank you so much, Lily, and really honored to be a part of this project. So essentially, we know that UHC is crucial for supporting good health across the life course. So through our report and our work, what we really wanted to do was to understand the extent to which LMICs have improved towards universal health coverage over the last 2 decades. And we also wanted to understand whether investment in universal health coverage actually results in good health outcomes. So what we did is we compared UHC with our Healthy Aging and Prevention Index. This is an online tool. It ranks 153 countries on 6 healthy aging metrics. This includes health, wealth, and environmental metrics to understand how well countries have adapted to longevity. So what we see is actually quite a positive story here. LMICs have seen a 60% increase in UHC over the last 2 decades, and inequalities have reduced by 25%. And that's largely due to the fact that LMICs have been catching up with high-income countries. However, it is worth noting that high-income countries still outperform LMICs by 22 percentage points. And what we found is when we looked at our Healthy Aging and Prevention Index and we compared that with the UHC coverage index, we looked at the top 30 countries. So those are all high-income countries. And we looked at the bottom 30 countries, which are all LMICs. And we see that people who live in countries in those top 30 countries live in countries that invest more in UHC, and they live on average 16 years more in good health than those those in LMICs. And it also tells us that those people that are living in countries that invest more in UHC are also better adapted to longevity. So we can very clearly see that investment in UHC has a top-level effect. It improves healthy life expectancy, which is crucial, ensuring that people live well for longer. But it's also worth mentioning that there are huge differences between LMICs. So LMICs are made of 3 income categories: low income, lower middle income, and upper middle income countries. And what we see is with upper middle income countries, if we compare them to high income countries, there's only a 9.5 point UHC difference between the 2 income groups. However, if we compare low income with upper middle income, the gap's of over 20 points. So huge inequalities within LMICs. That's unsurprising. Of the 153 countries that we look at on our index, 103 of them are LMICs. So there will be huge variation. But what we can see is if we look at the 4 metrics that make up UHC, there's been significant progress. And the one that stands out the most is infectious disease management, 270% increase. The lowest increase has been for service capacity and access, but it's worthwhile mentioning that across all 4 metrics, LMICs have improved the most. They've improved more than high-income countries, which again demonstrates that they are improving at a faster rate, which is promising and a positive story. However, when we look at catastrophic health spending, which is also within the UHC measure, catastrophic health spending, which essentially refers to the to when a household spends more than 10 or 25% of its income or consumption on health, we see that that type of spending, out-of-pocket spending, has increased for all income groups except low-income countries. So this is a worrying trend that certainly needs to be addressed when we talk about access to healthcare across the life course. So when looking at the specific metrics and when we compare it to our index, what we see is that countries that invest in reproductive, maternal, newborn, and child health not only perform better on our index, so they're better adapted to longevity, but they have half the fertility rate than those that don't. So high-income countries on average have a fertility rate of 1.7, and those at the bottom of index, the low and middle-income countries, have an average of 4. So wide variability, but this is a very good indicator of understanding child health and maternal health. So clearly we can see investment in this specific UHC sub-index results in good and better health outcomes. What we also see is that countries that invest in infectious disease management also rank higher on our index. They also have fewer deaths from infectious diseases. So when we look at high-income countries, of all the deaths in high-income countries, 7% are attributable to infectious diseases. Again, at the bottom, we see that 44% of all deaths are attributed to infectious diseases. So again, huge variation here. And this is despite the huge improvements still, we are seeing a huge burden of infectious disease in LMICs. So countries that invest in NCD management, again, rank higher on our index and report half as many NCD deaths per 100,000 people compared to those that don't. There's less variation in investment here that you can probably see compared to the previous graphs, but that essentially demonstrates that even small increases in investment in NCD management can yield positive and huge results. So among high-income countries, we see 329 deaths per 100,000 population compared to LMICs at the bottom of our index, that's 657. So again, huge variation. And then finally, we look at countries that we find that countries that spend more of their fiscal budgets on health have more comprehensive healthcare service and service capacity and access. So they have a healthcare that can better serve the needs of its people. And what we see here is that those are the top of our index, the top 30 countries, high-income countries, they spend on average 17% of their budgets on healthcare. Those at the bottom of our index spend on average 6%. But considering that they're aging rapidly, clearly that investment needs to be matched with the changes in demography. So I just want to finally end by saying that clearly there's a huge value in investing in UHC. Not only does it improve health outcomes, but it also shows that it enables countries to be better adapted to longevity. Clearly, LMICs have improved significantly, and this achievement should be celebrated. But it's also worth mentioning that in 2015, improvements have dropped and they've stayed more stagnant. So the majority of the improvements that we've seen has happened in the first decade. We need to ensure that the improvements that have been made are not lost, that we continue to build on that into the future. And it's really important that we do, again, particularly considering demographic change, but also recognizing that it's very unlikely that we're ever to meet universal health coverage for all individuals if we don't account for demographic change. My colleague Anna will speak more about this at her presentation, but I really look forward to the Q&A in the session, and thank you very much.
Thank you, Aaron, and some really fascinating graphs, I think, that really paint that link between UHC and healthy aging, like you say. And it's so worrying to see that particularly out-of-pocket payments are rising in some countries. I'd love to pass on to Caitlin Ward, who's joined us from HelpAge International. As I mentioned, as part of this project, we also, with the help of HelpAge International, spoke to older adults themselves to look at the lived experience and the barriers to access that many older adults in LMICs face. So I'd love to pass on to you, Caitlin, to share some of those findings.
Thank you. It's lovely to be with you all today. And I'm really particularly glad that that ILC UK chose to do these focus group discussions, because I think it's so essential that we listen directly to people about what it is that are the gaps. I mean, of course, we can see some of it from data, but the kind of data that you get when people speak about what their experience is really significant. So we're going to look at some of the barriers, but you can see the focus group discussion report. I think they'll paste a link in the chat so you can read it in more detail. But yeah, we can move on to the next slide. So we're just doing 4 main highlights. There's a lot more in the report, but I think it's important to hear directly from the people. So the first group of quotes are coming around the physical barriers. Of course, there's financial barriers, and that comes on the next slide. But the physical barriers we found are both related to rural and remote, and distance and cost of transportation, and then also physical accessibility of the services and the facilities when people arrive, particularly to do with disability and frailty and things like that. So a man from Rwanda said, it's not easy for someone with a disability using a wheelchair to reach the health center because the road is very steep, making it hard to navigate with a wheelchair, and even cars struggle to get there. In Mongolia, they have to travel 180 kilometers sometimes to reach the provincial center, and difficulty accessing with staircases because of wheelchair. In Zambia. Next slide. And then high healthcare costs is always at the top. There's some countries that have pretty good coverage, as Arun was saying, but in a lot of places, people pay for out of pocket for specialists. There's the cost of transport to the facilities, which is sometimes a prohibitive barrier. And then in some places, medicines or equipment, assistive devices, and technology all need to be purchased out of pocket. So you can see about this, like we might only pay about 25 to 34 cents, but the problem is if you need a specialist or medication. So that's in Rwanda, where there's relatively good national health coverage, and in Mongolia as well, although you can see that they say the cost of medicine keeps rising, so does the cost of treatment. We can't afford to get the treatment in our local areas with that cost. And then in Zambia, where there's less coverage, essential drugs are not available, and people need to go to private pharmacies to purchase because the public provision isn't there. Next slide. There are a lot of gaps. In HelpAge, we talk about universal health coverage fit for an aging world. We have a framework I'll share in the link so you can read more, and some reports specific to NCDs and specific, sorry about that, and specific to, trying to silence this phone. Okay, specific to NCDs and gender, as well as just the overall framework. And the thing is that, I need to block this. Sorry.
No worries.
Okay, so I don't even know how to block it. It's on my phone and my computer. I can power off my phone. That might get me somewhere. Okay. So what I was saying is that, it's the service provision and the continuums of care services and the health system building blocks. And you can see that here. The worst part is seeing different doctors not having training on the things that are needed. There's no continuity, or there isn't the type of care that's needed for older people, NCD services, rehabilitation, dementia, screening, all of those things. And people living in remote areas can't access health information. We find barriers with language. There might be basic health services, but not the things that older people might need in terms of prosthetics or eyeglasses or dental care. And that contributes to the cost. Yeah, next slide. And the last gap that we're looking at is about the social barriers, ageism, gendered ageism, and some of these other, and class and socioeconomic issues. And sometimes what happens is, an ageist view on the part of the providers that older people don't need it, like this man from Rwanda was sharing here at the top. and needing to go to a private hospital, or even in the patients themselves, sometimes feeling like, you know, they're done. They don't need the services or the care, and thinking it's just part of old age. And then there's this part, like the woman in Rwanda, the second quote, where other people are making decisions for them. And that's especially true with gendered ageism. So there's a lot more in the report. I'll encourage you to look at it, and I will paste some links if you'd like to read more about HelpAge's work on universal health coverage fit for an aging world. Back to you.
Thank you, Caitlin, and thanks again to HelpAge International. It's been brilliant working with you on this. And I think it's given clearly a small snapshot, but some real colour to some of these findings, some of the barriers that people face on the ground. It'd be interesting to hear later from the panel as well, whether some of this resonates, if you have ideas and solutions. And just to flag on this kind of point of ageism and things being taken out of your control, we 2 weeks ago, we had our big annual conference, and as part of that we had what was called a dementia bus, where you get where you could go, and it was a sort of experiential thing where you would get sort of glasses that would mimic some of the kind of sensory impairments that might come, and all sorts of things. But having done it, the thing that, you know, I think created the biggest reaction in people was the fact that you were being told what to do, you weren't being explained things. You got given a task that was whispered in your ear that you could just about understand. And in my case, it was finding some black glasses, and I was kind of trying to find them, see them, while I had loads of noise in my ears. And every time I picked something up, someone took it out of my hand. And that pure frustration, I think, was what landed most with people. And you know, it's much broader than dementia, clearly, but that question of, you know, agency and it being taken out of your hands in this case, I think really resonated with everyone there. So thank you, Caitlin. I'd love to pass on next to my colleague Anna, who's also been working on this project, that will share some of the policy recommendations that came out of this project.
Well, thank you so much, Lily, and hi, everyone. Really pleased to be presenting on our recommendations today. But I'd just like to start by saying we obviously know that we have had some really clear global commitments towards UHC. We had the Sustainable Development Goal of achieving UHC by 2030. We've had the triple billion targets, and we've also had the UN's recent Pact for the Future. So we do have these commitments, yet we're only 43% of the way towards achieving our goal of UHC by 2030. So it's clear that our health systems aren't all ready for longevity, and we know we need to strengthen our response and include a focus on demographic change when it comes to UHC. Next slide, please. So we are calling for governments to commit to identifying these challenges that arise from demographic change when it comes to achieving UHC, and really embedding solutions that will address them. So we've created 3 key recommendations. The first one is investing in national health schemes. Within this, governments really need to prioritise coverage for high burden diseases and expand financial protection through targeted subsidies to reduce out-of-pocket payments as well. And also within this, we'd like to see a strengthening of procurement and supply chains so that countries have better access to essential medicines. Our second recommendation is to position primary healthcare as the cornerstone of UHC. Now, this is because we know that 90% of UHC interventions can be delivered through primary care, but primary care needs to be strengthened in order to do this. So we are advocating for governments to establish or expand community health worker programs. These have seen great successes already in places like Rwanda. We also need rural care to be expanded to reduce inequalities between urban and rural areas. And we'd like to see expanded and improved healthcare professional training as well. And finally, within this recommendation, governments really should be working towards allocating 6% of their healthcare budgets towards prevention where it's fiscally possible. And our final recommendation is to build a data-driven and life course approach to UHC. So we know that older adults are left out of data right now. We really need to reform data collection to include all ages, and then leverage this data to set health targets for all ages. And within this, when we speak about a life course approach to UHC, we need governments to establish mechanisms for meaningful citizen engagement so that older adults' voices are heard on the policy level as well. Thank you.
Thank you, Anna. And just to remind everyone to do use the Q&A function. I can see there's one question there already. And also, I think we'll be sharing a link to the full report if you haven't had a chance to look at it yet in the chat shortly. So I'd love to open up to our panel. I'd briefly, I think, teased who we had on our panel so far. But I'd love to introduce Dr. Pamela Cipriano, who's the co-chair of UHC 2030 and also president of the International Council of Nurses, as well as a professor at the University of Virginia. We have Professor Srinaj Reddy, who's former head of public health in India. He's also an honorary distinguished professor at the Public Health Foundation of India and its past president. A global public health leader, he's advised governments, chaired expert groups on UHC and served on WHO panels. And finally, Dr. Socorro Escalante, who's World Health Organization representative for Mongolia and has extensive experience in WHO offices across the Western Pacific. So thank you all for joining us. I'd love to hand the floor to you in terms of any reactions. And perhaps, Pamela, I'd like to start with you. How do you think, from everything you've heard, that governments can strengthen national health schemes to expand coverage and ensure equitable access for all?
Thank you, Lily, and thank you to ILC for this webinar, as well as congratulations on the report that you're going to share, which I think is really critical. You know, you'll remember that one of the first action items on UHC that became incorporated into the political declaration was really to champion political leadership. And so we know that universal health coverage, again, requires that individuals are able to access the quality health care that they need, that it is of good quality, and it is without financial hardship, which is one of the big areas that UHC 2030 is focusing on this year. And even though we've seen progress in providing more coverage, as has been mentioned, there's also been an increase in financial hardship. And so that paradox is something that we know is really important for governments to be able to address. And why? Because we know that investing in universal health coverage saves lives, it boosts the economy. Some of the data in your report shows a significant return on investment. We also know that, again, people continue to not be covered in terms of getting the essential health services in the areas that you've mentioned, reproductive, maternal child health, infectious diseases, and non-communicable diseases. So basically, what we are focusing our campaign on this year is the out-of-pocket spending. We know that medicines are a huge driver for older individuals, as well as individuals who have many, many chronic conditions. Again, the NCDs. So trying to get a handle on the costs that older individuals are facing is really important. They have specialized care needs and need different kinds of assistance. One of the things that Sean mentioned is probably one of the most critical issues this year, which is the financing for development and the need to redesign and have fiscal space for more spending in health. While we're able to suggest globally, what percentage of GDP or percent of budget should be invested in prevention and health, we know that those expenditures in many places fall below the recommended amounts of spending. So the recommendations that we have for governments are really to expand health service coverage, prioritizing health, particularly financial protection in national budgets. There needs to be more public funding, and there need to be more effective national health insurance schemes. We also know that removing the financial barriers is really important for people who are vulnerable or in a marginalized population. Some countries have demonstrated how important it is to provide services at no cost and then be able to continue to strengthen their health system. We also know adopting and implementing domestic reforms can help create more dollars within a country's budget. And one of the key recommendations has been to boost revenue by adopting taxes on health-harming products, such as tobacco, such as alcohol, sweetened beverages, and those kinds of things. But the financing for development is really tied to the debt service agreements. And again, we know that debt distress is affecting many countries. They're spending more on repaying their debt than they are on health for their country. So that's a really significant concern. And we know that if we can't see that formula change worldwide, that we will continue to have countries that are not able to supply the number of individual health workers that they need, because they're not funding those positions. They're not able to add more dollars to their health budget for prevention. So in low and middle income countries, we really are encouraging governments also to encourage more donors and partners to align with these national priorities so that we can integrate services. And I know there's a lot of other issues that go into this in terms of, primary health care, and really looking again at how governments are structuring the services that they're providing. But they do have significant impact in terms of the elderly population. Again, the percentage growing in many countries, even though we have seen improvements in some of the UHC coverage in a number of nations where the percentage of elderly who are continuing to age in place could reach almost to up a third of their population. So we do need to look at how we can save more lives, address the financing, and be able to really assure those essential services.
Thank you, Pamela. Could I turn to you, perhaps, Dr. Escalante, with your experience both in Mongolia but also across sort of West Pacific, what have you seen that does work in terms of how governments can strengthen national health schemes? And I guess also on the side that Dr. Cipriano has mentioned of kind of financing.
Yes, first of all, I think I agree with Pamela on the fact that it has to begin with a fundamental vision and an overarching political will to ensure a wide coverage to the population. And in Mongolia, they have this Vision 2050, which incorporates how healthcare system is going to develop to ensure universal health coverage. But over the years as well, there have been a lot of improvements and refinement of the health insurance system to ensure that it is going to cover high percentage of the population, including the vulnerable. So just to give you this, for example, the current status of coverage in Mongolia, the coverage of health insurance is 92%. Of course, there are still challenges, particularly in the coverage for the herders, which is only around 44%, and students, which is around 15%. But generally, the coverage of health insurance has been increasing over the years, and it is also Mongolia is also preparing for the aging population and protecting the elderly by the government paying full of the health insurance premium of all 60 years old and above. So aside from the coverage, Mongolia has been trying to refine as well the effectiveness of its health insurance system and its financing mechanism. So they have now moved to a single purchaser with the performance based financing. However, in the past 2 years, they are also monitoring very intently the impact of the performance-based financing to in terms of the primary healthcare financing. So they have this scheme where on top of the performance-based financing and the single purchaser, that is the health insurance, they are also adding a capitation basis, particularly increasing the level of capitation in hard-to-reach areas and for vulnerable populations. So I think that despite the challenges that Mongolia is facing, the government is very intent in moving towards a universal health coverage for its entire population, including the vulnerable population.
Thank you. And Dr. Reddy, does this resonate with what you've seen both in India and I guess in terms of your global work?
Yes, indeed. Obviously, universal health coverage is absolutely critical if you want to have an efficient, equitable, empathetic, and economically viable healthcare system which serves the needs of everybody. And the growing elderly population are going to be very important constituency to address in terms of their needs. Particularly the healthcare needs will increase as the age advances. and to have an efficient primary healthcare system, which can not only prevent disease and promote health across the life course, but also readily recognize problems when they occur, especially when people are aging, and then ensure that they get the appropriate care at home or close to home, or get efficient referral systems in a bidirectional manner, which will provide care as needed at the advanced care centers and then return them back for continuity of care in primary care. That kind of a healthcare system is absolutely important. And for that, universal health coverage is vital for the appropriate type of financing. Therefore, we do recognize that whether it is a purely government-provided public finance model, or whether it is codependent also on private insurance, or whether the government programs themselves are being mediated through a purchased insurance program, whichever be the model, we have to ensure that everybody's healthcare needs are met without financial hardship. And the elderly are particularly vulnerable because they are no longer employed, their pensions may not necessarily be adequate, and their dependency on their family members may be problematic. And therefore, the needs of the elderly will be vital to address. And in India recently, the health insurance program that is government financed, the largest national health insurance program in the world at the moment, the Pradhan Mantri Jan Arogya Yojana, or PMJ for short, has now decided that everybody above the age of 70 years and above, will be a beneficiary of the government-funded health insurance scheme. That's a very vital measure. While preventive and promotive healthcare and initial healthcare services at the primary care level are available to everybody, additional financial protection for advanced care at secondary and tertiary levels, which is being provided through this insurance scheme, adds another vital element. And responding to the earlier comment that it is a bit of a paradox that has been observed, that even as UHC schemes are progressing, out-of-pocket expenditure in some cases is increasing. That is only to be expected for two reasons. As we're strengthening the healthcare system, more people's health problems, whether it's risk factors or manifest disease, is going to be uncovered and will demand care in the initial stage. If we can strengthen primary care, then you prevent a lot of disease which requires secondary and tertiary care. Secondly, as the health system starts offering more services, people's expectations and demand for services will increase. So this question of out-of-pocket expenditure increasing initially during wider UHC coverage, I believe is going to be temporary, and later on you would see the economic benefits of both prevention and timely care as the UHC program expands. But public financing is going to be absolutely vital. You cannot depend just on an insurance program. And that's why in India, we are combining both.
And how do you think you move to that sustainability? Because clearly, health and care are both, big economies as well, and they can drive that. But if there's that initial kind of gap, how do you get to making it sustainable? And this is really.
Well, obviously there are efficiencies that we'll have to realize. Not only more money for health, but also more health for the money. Investing in primary care itself reduces the requirement of secondary and tertiary care. Then you can also use telehealth services, which are currently now expanding, in order to make sure that everybody doesn't need to go to a secondary or tertiary care center to get the right kind of care and the right kind of expert advice. Then having non-physician healthcare providers who are technology enabled in primary care can extend the ambit of services and provide a lot of good care. So there are methods in which we can achieve these kind of efficiencies, even as we are progressing towards the universal health coverage model.
Mm-hmm. Just to open it out again, obviously we've just spoken about primary healthcare, and both Dr. Escalante and Dr. Cipriano touched on it as well. How do you think, and are there particular barriers in low and middle income countries all across the world to kind of really expanding this role of primary healthcare and a focus on prevention?
Is that a question for me?
Whoever wants to jump in, if you want to jump in. Good.
I believe that if you look at the way UHC Cube has been defined in terms of three dimensions: population coverage, service coverage, and cost coverage, primary health care or primary health services are best positioned to address each of those dimensions. Population coverage is universal in primary care. Everybody needs, in any population, primary care services at some point in life. Service coverage, it offers the widest bundle of services for a wide variety of conditions. And cost coverage, it is the most resource optimizing in terms of all healthcare needs and offerings. So I think it is absolutely logical for us to address primary care as the main fulcrum of a universal health coverage system. And that argument needs to be made. And people's satisfaction also to have healthcare delivered at home or close to home will be very high. And that will be particularly important for the elderly, whose mobility may be partly restricted, whose support services may not always be available through family members. And therefore, providing primary care as close to home is very, very important. I'm not suggesting that there should be dependency or there should be loss of autonomy, as has been mentioned in the earlier discussion. Basically, autonomy does not mean abandonment, and support does not mean dependency. We need to promote autonomy at the same time, ensure that they are adequately supported by the systems.
Thank you.
If I could add,
yes.
Oh, okay, sorry. Again, I think primary healthcare oriented systems are really much better able to meet individual health needs and the needs that are expressed by a particular subset of the population. And I think that's really the principle behind leave no one behind. And as we're talking about health equity and being able to assure that we don't try to have a one-size-fits-all, really primary health care is the mechanism to do that. So as we think about the determinants of health, we also need to be sure that we have a multi-sectoral policy approach. It is not just singularly health. It is the health officials. It is the financial officials. It is the social welfare. So really looking at how we prioritize, how we invest, as well as continuing to reinforce that it's really important to be looking at protection, education, and employment of the workforce. We know that in many countries there's an insufficient number of workers. We've heard mention of community health workers, making sure that they are also supported. The other, bringing care to the community, and again, I think this was briefly mentioned, because some of the barriers like transportation and proximity to be able to get to a location is a significant barrier for some elderly folks. Using technology, again, we've had some brief mention of that. Mobile clinics, telehealth, being able to have the resources be closer to the individuals that need them is important. There are examples, again, that services are brought to poor communities, again, which many older people may not have been able to access care. But I think one of the other key issues is that we know that prevention is the best way to address some of these concerns, to be able to prevent NCDs, to be able to prevent the morbidity. Where's that going to happen? It's going to happen in primary health care. So really being able to blend our focus on health promotion and prevention and have our governments be able to act because they know that there is a return on investment in prevention. I think this is a situation where we have a knowing-doing gap. We know it's important to invest more in universal health coverage. We know it's important to invest in prevention. Getting it done and making it happen and be sustainable is really the difficult part of this. You'll remember that the UHC 2030 Day that we launched our campaign in this past December was health. It's on the government. So, as Dr. Reddy was also saying, we really look to our governments to be the catalyst, to be the strategic movers and take action in terms of the investment. I also wanted to just stress the active involvement and inclusion of individuals in decisions about the services that they need, because it is also local, not just national budgets, and as was mentioned, the private sector that are important. This is an all hands on deck. It's an all government approach, and it is in many respects a whole of society approach. So we know it's important that we are talking to the individuals in our communities, that we're building trust in our older populations, and we are addressing their specific issues in addition to a very robust universal health coverage set of benefits within each of our countries.
Thank you. I think that was a very complete answer on that, on the question of prevention. I think you're right. There is a lot of knowledge out there. There are a huge number of reports that make that, value for money case. Talking of, there is a comment in the Q&A as well, talking about how actually UHC in some ways is part of that investment in workforce and future workforce that is needed. I wanted to move to a slightly different topic, which is around how we can better use, so we've spoken about tech, but how we can better use data to actually not only track where we are with these targets, but much better understand kind of shifting health needs. And there are certain sets of data where actually data collection ends at certain ages, which clearly in an aging world is unhelpful. Any thoughts from the panel around data and the use of that?
Yeah. Thank you so much. I just wanted to also comment on the second question on primary healthcare, which I am going to also connect to the importance of data and access to information. So from the many countries in the Western Pacific region where we have work, I think it's the most fundamental thing is that primary healthcare remains to be the most important mechanism for ensuring universal health coverage. But it's also important to note that primary healthcare systems are not shaped in the same way. It would really depend on the context of the countries and most importantly, how it is designed to cope up with the ways of life of the population. And this is very, very prominently demonstrated in Mongolia, where Caitlin has mentioned in her presentation that some people would travel 180 kilometers, 200 kilometers to reach the center of the province. So the geographical barrier is enormous. And then we have 30% of the herders population, which include some elderly people that are moving from one place to another. So it's really very difficult to track their location and to continue to sustain their access to services. But the government has developed its healthcare system in such a way that they have a very good distribution of what we call the health centers, but they continue to maintain what they call as a bug felchers. So these are the mobile doctors that are going to the herders' places to deliver services, but also to provide diagnostics. And WHO has been cooperating with the government of Mongolia to cover the whole of the country with what we call mobile health. And this is so important because the issue of data and digitalization can also be covered through these mobile health technologies that provide information from the people of the most common conditions that they have examined and reported through the mobile technologies into the center database of the system, where doctors in the provinces and also health policy makers in the center can be aware of what is happening on the ground. Having said that, Mongolia has been moving into a big digitalization of the country, both in all the government services, but also in health. And what we are observing is the most important role of technology and digitalization is to use the digital capacities of the country for people to access the services, even if they are in hard to reach areas. So, as well as, of course, using the digital technologies to, again, ensure that, the data that is coming or information that is coming from these provinces are going to be collated in the national level. I would like to mention at this point that Mongolia has been conducting what we call a national screening program. And this is a package of the screening and early detection services for each age groups that has been developed by the government. And as of now, 1.5 million of the population has been screened. And that information is being analyzed at the central level through our big data collaboration with the government to understand what are the risk factors of the different population, including for the elderly in the different provinces, and what is the disparities across the different provinces in terms of risk exposure and others. So what I would like to mention is that ensuring universal health coverage takes a multidimensional approach, not just from the financing, but also the design of the healthcare system. And data and information technologies is playing a big part in places like Mongolia, where people cannot necessarily be accessing the healthcare services due to geographical barriers.
Thank you, and apologies, by the way. I saw that you'd raised your hand after
It's okay.
after the fact. It hadn't flagged up for me. But that's and clearly it's fairly unique challenges, but the question of access is one really across the world. And I think the sort of mobile health is really important. And it's brilliant to see the screening program you're doing, and I hope that that data is really useful to target interventions. Dr. Cipriano or Dr. Reddy, would you like to come in on the question of how we can use this data to better target services?
For sure. I applaud the work that's being done in Mongolia. There are a number of countries that are doing, widespread data collection. I want to just emphasize a couple different points, which is also to start out, if we want particularly the elderly included, we also need to address data literacy. Not health workers also have data literacy needs, but I think that's another concern that doesn't really pop up when we're thinking about how do we really assist with being able to then understand the needs of populations. Another aspect of that is self-care. Very few countries have ways to incorporate that data that individuals are accessing different services or seeking services, and what is the impact of that. But we want to be sure that everyone, including older adults, are included in routine health data collection. But then once we have these large databases, we do need to have methods in order to be able to disaggregate the data based on age, sex, gender, geography, socioeconomic status, and disability. That's really where the governments then have a responsibility to say, how do we stratify the needs? How do we then look at strengthening our health systems to be able to meet the different needs of different populations? And it's clearly a challenge. Information systems are not inexpensive, but they really are absolutely fundamental for decision-making at the government level. So I think there's a need for us to really look at the disaggregation of data and make sure that we are, again, helping those who are on our front lines to be able to understand how they can use that information, and make sure that we're, again, checking with our governments and other stakeholders to be sure that they know then what are they monitoring, who is being left behind or who is being pushed behind, as we understand the needs of different populations. But I think integrating, age-related health trends and knowing the specific needs, and then incorporating that into our policy planning, not just financial planning, but overall health strengthening planning, is really important, so that we are customizing aspects of our universal health coverage benefit plans to make sure that we are then addressing the health equity.
Thank you. And Sean, I just saw that you turned your camera on again. Did that mean you wanted to come in? No. I'll pass on to Dr. Reddy then.
Well, basically, I think we need accurate, timely, and representative data systems in order to even assess how universal health coverage is functioning. Because if we are really looking at the two metrics by which universal health coverage is being judged, one is the level of financial protection and the other is the level of service coverage. Now, if the service coverage is inadequate, there can be a lot of unmet needs, and that can actually give a false impression of low out-of-pocket expenditure. So that is because of foregone care. We will never be able to capture only by looking at financial protection, whether the care is being adequately provided to all those who need it or not. And that's why we need good data systems to capture both those elements, to judge how UHC is progressing. And particularly in the case of the elderly, where there could be a certain degree of vulnerability, neglect, and isolation, this becomes even more important for us to gauge. And that is going to be important also for us to gauge whether the healthcare personnel in the system are adequately distributed and available, or whether there are stockouts of medicines and equipment. All of this data will throw light on as to how the healthcare system is efficiently functioning and addressing the various elements of universal health coverage. Of course, if we also can utilize some of the emerging technologies like artificial intelligence, as well as some of the big data integration platforms, we should be able to build in social determinants of health and then start looking at vulnerabilities in a much better way and be able to give not only personalized medicine, but also personalized public health and identifying particularly vulnerable groups who require special attention. Because equity for me exists in two dimensions. One is the horizontal dimension, where everybody gets all the facilities that are needed or by all the services provided by the program, but also a vertical dimension in which we allocate additional resources or pay special attention to those who have suffered health inequities or likely to be also marginalized by the services that are being offered. How do we focus greater attention and resources on them? For all of these, we do need to bring in the social determinants of health also to profile both patients and populations that are being served.
Thank you. I'm going to turn to some of the questions and comments in the Q&A box now. And one that's been voted up a few times. What would be some tracker coverage indicators that we could consider to assess how good health systems are doing in providing care for older people? So this is a question from AJ Tandon, who says, currently the WHO UHC Service Coverage Index does not capture care for the elderly. Any thoughts? I guess this comes back to that question of how do we measure how we're doing, that we do look across the whole age span. Sorry, anyone want to come in on that question?
Well, yeah, again, I think some of the challenges that we've mentioned in terms of making sure that we are collecting data that is reliable, and that we then have the analytics to be able to then disaggregate the data to really look at what's happening to different populations. Right now, we're collecting, as you've heard, like, two major issues: the coverage, and then the out-of-pocket expenses. But I think it's stratifying the data. It's trying to understand what is happening in terms of the different segments of the population, and taking the specific indicators as you've done in your report. How are we doing on reproductive maternal child health? How are we doing on infectious diseases? How are we doing on the cost of care, the amount of out-of-pocket expense? But doing that again with some ability to understand how that is affecting different groups in the population. I believe in countries where we have those systems that are up and running, it's another level of data analysis that can be done. And so I think it's really looking at refinement and how do we again work together to say, here's the next level of data that we need to have. And again, some countries are able to do this right now, but I think it's looking at what would be the most beneficial, because we already do some of this analysis. We particularly have better data on children, and some of the metrics that we use just to define health, and looking at the death under 5 years and those kinds of things. So I think it is taking a step back, taking a look at what metrics, now that we know some of the progress that's been made, but say, how do we use some of the data in a different way to really understand where do we need to focus these next policy efforts and the expenditures that are necessary.
If I may come in on that, I think we should not limit ourselves only to quantitative data. Quite often we make the mistake of saying only we see numbers and then the quantitative data are what represent the reality. We do need to undertake mixed methods research and use qualitative data as well, including things like people expressing themselves through what's called the camera voice, where people record their reactions to the healthcare system or their unmet needs or their level of satisfaction. And that's recorded by groups which can actually compile the data and then present to the health system managers what's actually happening on the ground level. So unless we actually also start using those mixed method research methods, we may be numbed by some of the quantitative measures, which may not necessarily reflect the ground reality.
Thank you. And there are a lot of comments here about data and in the Q&A and how it could be better. But clearly, you know, this comes into our broader challenge around that this does all cost money, and then using that adequately. Dr. Escalante, did you want to come in?
Yeah, thank you so much, Lily. I think in terms of tracer indicators, while maybe there's no like one big framework for tracer indicators on aging and elderly access to universal health coverage, I think it's very important for countries to define their own outcomes. For example, if in Mongolia we are developing the Healthy Aging National Action Plan. So in that plan, we define the outcomes in terms of access to services, coverage of the elderly, and practically the countries can actually design their indicators to measure the progress along those outcomes. So I don't think that, yes, it's very important to have tracer indicators at a global level, but at the end of the day, it is how we achieve in countries by ensuring that our outcomes are met through the different interventions that we put in the strategies as well as in the plans.
Thank you. Now a slightly different question, but I would be interested in thoughts from the full panel on this. Clearly in the context of what's been going on over the last few weeks as well, what impact do you expect the recent US funding freeze might have on actually this entire agenda, and what are the other ways that we can mobilize funds to support health systems in low and middle income countries?
Well, this is a very tragic move, if you will, in my personal opinion. And even though there will likely be some mitigation in terms of the amount of funding, I think everyone is justified in worrying that as programs might be halted, as services will be diminished, as we see the disruption that has occurred, that there will be a major backslide in terms of being able to adequately address the needs of some of the most vulnerable people around the world. And I know recently I was at some UN meetings about a week and a half ago, and the conversation is that, yes, the private sector, we want to step up, but they are not going to be able to fill all the gaps. So again, I think it is going to be a whole of society approach with some rapid movement to say, how can we make sure that we address initially the needs of those groups that can be vulnerable right now, as well as how do we think about coming together to mobilize additional resources. As once again, we know that the funding for development will be coming up at the end of June and July, financing for development. And while that was already a critical need to say, how do we provide different opportunities? How do we restructure the mechanisms to be able to have countries better handle their debt? Now, I think there's an additional burden on that discussion to be able to say, how do we work together to be able to make sure that where there were funds, where there were human resources deployed, to be able to bring those funds, bring those supplies, make sure that medicines are provided, vaccinations, food, all of the things that round out health. It's not just seeing a clinic. It's all of the things that support a healthy life, and particularly from across that lifespan. So I do think it is a critical moment for coming together, again, whole of government, whole of society, to look at where we have new gaps and how we can shore up initially the critical survival needs that we know many of the aid programs have been providing, but then also looking longitudinally as countries take stock of where have these programs addressed health equity and inequities, and how have these programs also been able to help with infectious diseases, with NCDs, and be able to come to some kind of new approach that might be needed in areas where funding is not going to return.
Thank you. Yeah, Dr. Reddy.
Well, I think this is extremely regrettable, and it's definitely going to put the global health agenda on the back foot for a while. But it's also a great opportunities for countries to reassess their priorities and to restate their confidence in universal health coverage. Looking back at history, the United Kingdom, Britain, embarked upon its universal health coverage program soon after the Second World War. Japan, when it started reconstructing after the damages it suffered in the Second World War, undertook universal health coverage. The Asian tigers, as they were called, Southeast Asian countries, when they suffered the huge financial crisis in the end of the 20th century, they then undertook extensive investments in universal health coverage in order to invest in the health of the people. That is where the UHC programs blossomed around the world. And they yielded dividends in terms of a healthy population, good economic returns, and showed that UHC is a sound economic investment. So while I completely agree that global solidarity calls for action on part of all countries to pull together and get resources from governments and private sector and others in order to really fill the gap that's been created by the US withdrawal, including, as has been pointed out earlier, debt waivers, all those are going to be important. I think it also is a reminder to countries to look at this as an opportunity to strengthen their health systems on a note of self-reliance and adopt universal health coverage with greater commitment as a way out of any potential downside.
Thank you. And yes, let's hope that this does lead to something positive. Dr. Escalante, did you want to come in as well?
Thank you so much. I think there are really some critical issues that has been affected by this phenomenon, and particularly, for instance, the delivery of critical medicines for HIV/AIDS and vaccines in many parts of the world are really directly affected. But this is also, of course, an opportunity for us to have another look at how we ensure health services are delivered equitably to the population in its countries. And I think it needs us to go down to the ground and really understand what are our fundamentals, what are our bottom lines, what are those we need to ensure that they can be sustained at the country level. And this would include, for example, the capacity of the country to address and mitigate or prepare for outbreaks and continuing threats on health security. And of course, the another one would be ensuring that, again, the services and universal health coverage could be sustained. And what we are observing is that over the years, even not necessarily due to this pullout of funding, is that it's very important for governments to invest in health, and the sustainability of their health systems is key. Whether or not the funding is going to decrease or increase, when your health systems are resilient and able to deliver services, then the people will not suffer, and we can continue to achieve our public health goals and our public health outcomes. So, for example, last week we had a partners meeting here in Mongolia, and we are trying to examine how economies are growing, including for Mongolia having been, for instance, classified as an upper middle income country in the past 2 months, 2 or 3 months. But what does this mean, this classification, into ensuring that the benefit of an economic growth is actually felt from the health and the social perspective? So our common conclusion is, of course, to engage the government and ensure that investment will have also to be provided in the social and health sector. And we need to make a very important case to make policymakers understand that the benefits of health is a benefit for economy. So what I'm trying to say here is that there are other areas that are opening up which we may not have been providing a lot of attention before, because we are so intent in providing specific needs or specific services and programs. But with the decrease of funding in those areas, we are now exploring the broader and the bigger picture of how health can really be shaped in countries. So although yes, again, fundamentally, there has been an impact into the direct delivery of services, particularly in many countries and to some vulnerable populations, but it is also an opportunity for us to really look at the broader perspective of how health should be shaped and delivered in countries.
Thank you. And I think this thing of really looking at what each country wants and needs and what it's good at is mirrored a little bit here by, there's a few comments in the chat around, well, Jean Jackson, who's one of our trustees, talking about how actually lots of these concerns are similar to things that we see even in the UK, so things like providing local services and so on. And there's another question as well around what high-income countries can learn from low-income countries or low and middle-income countries in terms of delivery. Dr. Escalante, obviously you mentioned a few examples of things that are going on in Mongolia. What are some examples of where things work really well that you have seen, so across the panel, that could be scaled in other LMICs, also high-income countries?
Again, I think it's really fun, basically about how do we shape our health system structure based on the ways of life of the population. So there used to be a kind of thinking that what is good in UK could be good in Mongolia, could be good in the Philippines, could be good in Vietnam. But we already know that that is not going to be working. To me, it's understanding first and foremost what is the I'm talking about way of life, because the access, whether in our experience, for example, I'll give a very practical example. If you put a health facility in one community that does not serve the needs of the population, it's not going to be utilized. But it's a two-way approach. So as we are providing the services, the community will start to be understanding what are the services that are going to be delivered. At the same time, the health facility will have to listen and observe what is happening in the community in terms of this disease pattern, and it is going to adjust. So to me, providing health services and setting up a healthcare system in a community is both, it's kind of a relationship between the service delivery facility and the community. It's listening and responding and adjusting. So I think that in many countries in this side of the world, where we do not have all these technologies at the same time and cannot afford all, many of the countries cannot afford high technologies immediately, it's really starting from the very basic of what is needed: immunization, essential medicines, diagnostics for NCDs, etc., etc. So I think that also one of the phenomenon that we have been seeing in other countries as well is the very fast infusion of technologies in the countries, but which are not necessarily utilized because the community is not ready to absorb these technologies, as well as someone mentioned the readiness of the human resources. So it's very difficult to say we can scale this up and we can learn from one country to another and maybe adapt what is the good practices from one country to another. It really, to me, working in the different countries in the region is first understanding what is the needs of the population, and then making decisions on what is a good practice that I can bring in, but what is a good practice that can effectively be used by the population as well.
Thank you.
Yeah,
And I'd like to, oh yes.
Well, I was going to say, I would support what Dr. Escalante was saying. It really does have to be based on the needs of particular communities and countries. A couple other things that we do have good examples, I believe, particularly on the insurance schemes, when countries have made the decision to either use their social welfare system to cover those that are unable to provide health insurance fees, or be able to say, at a certain age, that the insurance coverage will be provided. We've seen much better uptake of care, and that's part of the big commitment to universal health coverage. And again, we've seen that places like Ethiopia have vouchers for the poor. Thailand is not only covering all their population, but now they're also covering refugee populations, and they have a commitment to bring care to their communities. We've got, again, I know Rwanda was one of the examples in your report. So again, looking at how can we customize within countries ways to finance care so that more people have that greater access. One other thing that hasn't come up that I think is complicated is that some will say there's plenty of resources to provide services, but it's not coordinated. I think this opportunity right now for countries to do some introspection and say, who is providing? Who are the NGOs? Who are the other private funders? How can we bring them together with our governments to look at where we are falling short in terms of being able to provide coverage in our communities? Are there different ways that the finances can be used differently with additional collaboration and cooperation, and take a look at whether that actually is an advantage in terms of strengthening health systems in particular countries.
Very good point. Thank you. And as we're coming to the end of our session, I would like to ask everyone, including colleagues at ILC, Amgen and HelpAge, to think very briefly if there was one thing that you could see governments do that could help us get towards UHC 2030, what would that one action be? So I'll let you think for a second, and then go around. And in the meantime, I think we've shared the link to the report as well in the chat. Thank you everyone for being so active on the Q&A. And I'm afraid I haven't got through all the questions, but it's been great to see the discussion there. So who would like to go first, I guess? If not, I will pick perhaps on someone from the ILC team, what you've taken from the discussion today. Aaron.
I can come in. And I mean, I think there's so many important points that have been raised in today's discussion, but I think one of the key things that we set out to do in our publication was really to demonstrate the value of considering demographic change or understanding the issues that come with demographic change and implementing solutions and strategies that account for it. So for me, I think that's really important, not just for UHC, but across all healthcare strategies, is to really take a measured approach to understanding how demographic change may affect healthcare access and incorporate that into all policies that are relevant to improving health outcomes across the population. So for me, that would be a key thing, demographic change as a sort of focus underpinning all of the work that happens in health, including universal health coverage.
Thank you. Could I come to you next, Dr. Reddy?
Well, obviously, everything that we have spoken about UHC matters. But if you want me to pick up one, I would say people-partnered primary healthcare.
Thank you. Caitlin.
That's a good thing for me to follow on, because I was going to say the same. It's really, all of it's important. And in some ways you could say financing is the most important, but for HelpAge International and our network of organizations, what we're working to do is to strengthen the people and civil society engagement with the government and health systems to strengthen care for and with older people. So that's partly about putting older people at the center, and it's partly about engaging the government in the kinds of things that are needed to share examples between countries, to show what's happening at global level. And so for something like the NCD high-level meeting this year, we'll be working to influence the global outcome, but we'll also be working with our partners in country to see if they can shape or change the dial on inclusion of older people within the NCD policies.
Thank you. Dr. Escalante.
Yeah, to me, it's still going to be primary healthcare, but I would like to broaden it in a way that a primary healthcare that is supported by strong social structures, including social capital. And as Dr. Reddy is saying, it's the community. So again, emphasizing our experience working in this area for many years, building healthy and productive population, including for the elderly, takes a relationship between service providers and the community that are utilizing it, and how this community is also contributing back to a better informed healthcare and social systems that would take care of the needs of the population. So, for example, we have been talking about how can we make primary healthcare as the community focus of like the window of opportunity for also introducing not only health services and universal health coverage, but building social capitals and understanding how the societies and communities can work better for their health.
Thank you. Can I pass on to you, Anna?
Yes, my one thing would definitely be expanding financial protection through things like targeted subsidies, just because we have seen such an increase in catastrophic out-of-pocket spending. Yeah.
Thank you. Dr. Cipriano.
So many great things have already been said, and I would reinforce that I think one of our major takeaways is that we have to move quickly on supporting primary healthcare with our financing, with our prioritization, with recognizing that many things hang on primary healthcare, whether it's health security, whether it is social welfare. So I think renewing that commitment and focus that if we want to achieve universal health coverage, the way to do that is to strengthen and reinforce our investments in primary healthcare.
Thank you. And finally, over to you, Sean.
Well, I might lean on something Dr. Escalante said, is that ultimately all health is local. So it's very hard to recommend one thing. That one thing, however, does need to be contextually appropriate. And I think between now and the time we're having the final readout of the SDG goals, it's going to be focus and focus on the particular thing that's going to be relevant for the health system. For countries that haven't made choices to move towards UHC, it seems like a phenomenally difficult thing to do. However, making a choice in certain parts of the system, and many of the examples given today, protect the older people, ensure that PHC is moving forward, really has to be my one thing.
Brilliant. Well, what a brilliant way to end. Thank you all so much. So all of our speakers, thank you to HelpAge International, to Amgen, and everyone who's been so engaged on the Q&A today. We'll send a follow-up email with lots of links as well to everyone, and I just wish you all a great day, whatever time zone you're in, and thanks again.
Thank you. Bye.
Thank
Thank you very much.
Bye.
Goodbye.
Bye.